Hi, everyone. This is Dr. Christiana Best, host of the podcast Inside Out, Outside In. This podcast was developed for and by colleges and universities and its surrounding and supporting communities. The goal of the podcast is to inform, educate, and build community as well as inspire change. The views expressed on this podcast do not reflect those of any college, university, or institution. Thank you so much for that. The statistics is probably higher now because my statistics was from 2016. But we all know the story. If we don't, we all know the story of Serena Williams, where she shared that after giving birth, she was totally ignored when she shared with her medical team what the symptoms were, shortness of breath and all that she was experiencing, and she was ignored. And given her platform and given who she is, and she's been ignored or she was ignored, I worry about the average woman who talk about or share with her medical team what she's experiencing, because she probably isn't as empowered as Serena. And of course, if she's ignored, she probably is unable to or does not have the resources to push back, right, the way she should. So just to also let you know, we have an interview format. So I have some questions I've prepared, and I'm going to direct it at both Dr. Canty and Lakeisha. But before we get started, I want to take a moment and have Dr. Canty and Lakeisha introduce themselves. So I'll start with Dr. Canty. Can you introduce yourself, particularly your professional background?
Yes. Hi, everyone. My name is Lucinda Canty, and I'm currently at the University of St. Joseph, but I will be going to UMass Amherst in the fall. So I'm excited about that. So I am a nurse midwife. I have practiced in a lot of different settings, mostly in the community. And right now I'm still practicing reproductive health at the University of St. Joseph. And I do research related to maternal health, particularly health disparities. And I'm launching what's called Lucilles House, which is an initiative to address, maternal health disparities in the Black community and other women of color, and not only talk about it, but develop solutions and using the voices of the community.
Thank you for that. Lakeisha?
Hi, I'm Lakeisha Rivera, and I am a nurse certified in inpatient OB, obstetric nursing, and also a nurse midwife. And I currently am director of clinical operations at Women's Health Connecticut. I've been professionally in nursing over 20 years. First couple of years was just regular med surg, and the last 20 years I've been in women's health in some capacity. And currently I'm working on the business side of women's health, business side of healthcare, particularly women's health, where policies, procedure, guidelines are made. And my passion has always been the Black and Brown community, the teen community, the homeless, substance users, because I noticed during my clinical work that they are underserved, they are misinformed, they are not cared for the same. So I'm a huge advocate, and this work is near and dear to my heart. And I'm excited to be working with Lucinda and ready to get this discussion going.
Thank you very much. I just want to point out to the audience that the three of us are wearing T-shirts. And Lucinda, you want to tell them what this T-shirt is about and where it's from, because you have the connection.
Yeah, so this T-shirt is from Birth Nerds. And Birth Nerds is her name is Lauren Turner. She's an artist. She creates T-shirts, artwork that really promotes breastfeeding, childbirth, especially among, Black women, just to make it normal and normal to have discussions about it. So she's located at birthnurse.com. And this t-shirt it's a history of maternal health disparities for me, because it, we have a long history. We have a very long history. So, anyways, we just wanted to kind of uplift her, but also highlight the importance of, looking at Black maternal health.
So I'm glad you started to look at that, but because as I mentioned earlier, the risk of Black women dying in childbirth is so high as compared to their white counterparts, and any other group, as a matter of fact. And as I mentioned, for some it says 3 to 4 times higher, for others it says 2 to 3 times higher. So can you share with us why that is, and why those outcomes are so poor?
Yes, and we have a long history. If you look back, even to going back to slavery, Black women were looked at as a property. So we were valued. So childbirth and us being safely delivered was important. But then when you start to look at the turn of the century, when slaves, were free, we were not used the same way. And so our health was not that important. And we did rely primarily on, traditional midwives. And we had safe care. We were in the homes, there was a sense of community, birth was celebrated. And then there was this change from, people realizing first they could make money off of delivering, off of childbirth, not only delivering, but experimenting on them and learning techniques that are still being used today. And so when there was a shift from home births to hospital births, we start to see, instead of our mortality rates among Black women decrease, they actually start to increase. And what happened was, that there was a lot of kind of campaigns to eliminate midwives, saying they were unsafe, they were uneducated. So women were shifting to obstetricians and delivering in the hospital. But when you look back at the history, is not true. Our numbers were better. So at that time, there was a 2 to 1 disparity between Black women and white women. And now we're at 3 to 4 times more likely to die. And even look, I just want to read some statistics. In 2019, 44 out of 100,000 Black women died during childbirth. And for white women, it was 17.9, and for Hispanic women, 12.6. So 2020, when we even had, there was again years where this was highlighted, that there were issues in the Black community in regards to maternal health. We thought interventions were being done as people talked about it. But when you look at 2020, it increased for Black women to 55.3 per 100,000, and for white women, 19.1. So the disparities still exist, and we're bringing attention to it. But the problem is that we blame Black women for the maternal health outcomes, instead of looking at our history and looking at a system where we're not really supposed to be a part of. When you really look at what hospitals started, again, doing childbirth, and that's a long history I can't go into at this time, but I want you to take a look when you have a chance, because you'll see how we were treated. I'm talking about being on infectious disease units and delivering your baby, because there were segregation in these hospitals. But right now we blame Black women for their outcomes, and we don't look at the system. So when I first started looking into maternal health, and I recognized that Black women were more likely to die, I didn't even realize when I had my son Ryan that I could have died. And I had some risk factors. I had a cesarean. But when I started to ask the question, why, I'm told, oh, they're poor. They don't get prenatal care. There's no access to care. All these things that we're blaming the woman, but we weren't looking at the system. And that's where the issues lie. Because when you're looking at quality care, you're looking at access to quality care. So care where you're seen, you're heard, you're respected, you're treated with dignity, and you're in an environment that's free from discrimination. That's quality healthcare. And that will help improve the outcomes among Black women.
Right. So thank you for that. Lakeisha, the next question is directed at you. Some of the leading causes of severe maternal morbidity in Black women include cardiovascular illnesses and hypertensive disorders. Can you share more about these conditions and what can be done to prevent or minimize them?
Sure. So there's 4 types of hypertensive disorders and pregnancy. So you have chronic hypertension, where the birthing person has hypertension and then becomes pregnant. Then there's gestational hypertension, where they get high blood pressure during pregnancy. Then there's preeclampsia or eclampsia, where the high blood pressure becomes more severe, and there's effects on the liver and the kidneys. The numbers, their values go up. And then eclampsia is where the stroke, seizures, things like that, which then leads to death. And then there's the last category of hypertension with superimposed preeclampsia. Now, all of those obviously have varying degrees of severity and can eventually lead to death. For patients that come in with chronic hypertension, most of the time it's uncontrolled, and what I've seen is the OB provider does not do due diligence to reach out to whoever is caring for that patient for the hypertension. So it's not like a wraparound service where they have a discussion with each other to make sure that their hypertension is under control. So they come in hypertensive, and the OB tries to put them on meds, do what they think they need to do to get them under control, but it may or may not work. And then it's like a domino effect. Same thing with gestational hypertension, preeclampsia, things like that. I'm a big person on education. So if a person doesn't really understand their diagnosis, what could happen, why they need to take meds, why they need to make changes, that's an issue. So that's to like Lucinda's point, it's about the care that's provided. So a lot of times the patients, you look at the doctor, okay, this is what I have. They told me to take this med, and then that's it. But if you don't really hone in on the educational part of it, and the other part, as Lucinda said, is listening, because that's the other thing. There's a lot of patients who have had certain symptoms that come along with these disorders, and they've been ignored. And it being ignored will then lead to the severity, which then leads to the morbidity, which could then lead to the mortality piece. And that's the biggest part of this. So yes, the disorders are there. They can be treated appropriately, but it's the ignoring part that's the problem.
Mm-hmm.
Mm-hmm.
Yeah,
Right.
yes. And just the screening when you know that someone's at risk because they're not being screened or educated. So that's an important piece of this.
Yeah, I was going to ask the next question, which is what role does racism play into it? I think you start to talk about that not being heard, not being valued, right? What are some other things, particularly in terms of the interpersonal aspect of it, as well as the systemic aspect of it that's happening today, that's contributing to this, large number of Black women being in danger?
Yes, and I'll use pain because that's the most obvious thing. And that has history also. That's why I feel like it's so important. If you want to address the health disparities, look at the history of those who are most impacted. And when we look at history with Black women, we were told that we weren't smart enough to understand pain. I actually found medical journals that was teaching students at the time this. We don't understand pain. We're not smart enough. So, but when you look at that, it starts back in slavery, where in order for us to deliver a baby and then go back to working in the fields, in order for us to have a baby and then someone take the baby away, we don't feel pain. So it's okay to take their babies away. It was like these stereotypes were started to keep us from getting the things that we need. And unfortunately, it still happens today that when a woman complains of pain, look at Serena Williams, she was feeling chest pain. And our nurse was like, oh, just relax, you just had a C-section. There was a woman that I spoke to who had chest pain. Her doctor said, oh, you just have a little angina, go home and rest. And then when she went home, she almost went home, another person stopped her. She was in heart failure. She had to be admitted to the ICU. And they told her if her heart didn't improve in 3 months, she was going to need a heart transplant. And she just had a baby. So it's like we're ignored when it comes to pain, but it's not only pain, but that's the most obvious one. And I just want to say with pain, when we're looking at systems, When you say, oh, well, I followed the pain scale, so that's why I didn't give her any medication. Or you say, well, she's been in here 3 times already with this pain, so, we just thought she was exaggerating. It's like those kind of excuses where it's still blaming the woman because you're saying she's not using the system right. And then that pain scale, I got to go back to that. We number with somebody how someone feels pain, and then based on that, we determine how much pain medication we're going to give. But studies have shown that Black women are less likely to be screened, less likely to be assessed, and less likely to be given pain medication even after having a cesarean birth. So there's just so many things in the system. When we're looking at racism, there's so many things in the system that support people treating us wrong, because either we're blamed or the system is blamed.
Yeah,
and so it's the medical gaslighting that they're now, finally acknowledging, where symptoms are inappropriately dismissed as minor or psychological. And this is prevalent, like you said, Lucinda, in pain. It's prevalent in heart disease. It's prevalent with ovarian cyst complaints, endometriosis. You're told, or it's anxiety, or you have depression, or you have really bad periods, painful periods. Just take this and go see a psychologist. And it's like, that takes away the person's power, that you really start to think, well, maybe I am crazy. Maybe my pain isn't as bad.
Yeah. And it goes back also where slaves were believed to not, people who were enslaved were believed to not be able to feel pain, right? And medical schools still train their doctors under that same premise. So it's still going on. So I have a lot of friends here who are Black women, but they're also immigrants. And can you tell me if this is happening in some of the countries where Black women are land, and if not, what happens when they come here? You know what I mean?
Yes, and this area still needs further research, but they do see, like I'll use African women, that their health outcomes are better, not extremely better, but better than Black women who were born in the United States or who have lived here for a long time. But the longer that they're here, we start to see the mortality rates increase. And one thing that I've heard from women who are immigrant women was they didn't understand racism until they came to the United States. They didn't understand it in the healthcare system. Coming in, like I had someone recently tell me that someone asked her if she speaks English, if she can read and understand English. And she was like, I was born in England. So yes, but it was the assumption without even trying to get to know her first that they made that assumption about her. Or it goes to, you don't understand what we're saying, so I'm going to talk to you like you're a child. So when they start to experience that, because we're really looking at the impact of chronic stress from racism. So when you first come in and you're not aware, your outcomes again are better, but then as you start to learn and become a part of the system, we start to see that the impact of that stress. So we need more research in the area, but we are already seeing differences. But again, we're seeing those women, the longer they stay, then their health outcomes are just as poor as Black women who were born here.
What about women in Brazil? Because there's a very large Black population in Brazil, but we also know Brazil is a very racist country. So how does that show up, if you happen to know?
Yes, it's the same as the United States. Black women or women with darker skin have higher mortality rates. It's very comparable to the United States. It is really interesting to look at the research in that, because you see that women who have lighter skin have better health outcomes in Brazil, and women who have darker skin have poorer health outcomes, and also even talk about the same issues that we talk about here in the United States of not being believed, made to feel like you're exaggerating your symptoms, and also being blamed for your health outcome.
Right. That's really important to know. I know that you did your research on, you did a qualitative research project with women who were pregnant or gave birth shortly after the research. What did you learn? What did you learn from that research that you can share today with us?
Sure. One of the most important things was about health education and not receiving education on the complications. Like Lakeisha was mentioning earlier, how preeclampsia impacts every organ in the body, but women believed that preeclampsia was just a swelling of your feet. You know, your blood pressure may go up, but they didn't realize how severe until they were in the hospital, told they were not sure if they were going to make it. So, but even recognizing the warning signs, women didn't know. So they were driving, like someone had a headache. That's a classic sign of preeclampsia. And she didn't know. She was driving her daughter to daycare, doing chores. And then it was a friend that was like, something's not right. And as her friend was driving her to the hospital, she started having seizures. You know, she was okay and the baby was okay, but she was like, no one told me about that. You know, and it goes back to the racism. She said, oh, they couldn't wait to tell me about, you know, WIC, you know, getting government assistance, but no one told me about the complications. The other piece that was really important from my study is the relationship of the healthcare provider. The healthcare providers could be either a source of stress or a source of support. Women who felt that support said their providers made them feel like they were part of the team in their healthcare, that they were part of decision-making. That even one woman told me that her provider told her, any problem is a big problem. I don't care if you think it's small, I want you to call me. And she did do that. She ended up having postpartum preeclampsia, but she felt that it was the way that her provider was on top of her. Other women felt like they were either exaggerating, that they felt like they were part of somebody's routine. You come in the room, you do the blood pressure, you do your weight, you know, it's very technical, but not even looking at them as being even human. And they felt that. And between the two of them, even though both groups have very severe complications, the ones who felt they didn't have a relationship with their provider reported racism. And those who had the support, even though they had this life-threatening situation, they felt that their provider was there and they appreciate the care that they received. So as healthcare providers, we have to decide, are we going to be part of the problem or part of the solution? And they have to realize our patients are watching us and they know, they can see implicit bias. You may not realize it, but they can see it.
Well, thank you for that. It actually brings me to this thought I had, and this is directed at you, Lakeisha. Most hospitals and white providers, and even some providers of color, medical providers of color, don't think that they're racist or that they're operating under this racist cloud that we're talking about, right? They think that they are providing the same service to everyone the same way, regardless of the person coming into the hospital or the medical facility. But, you know, so with that in mind, how is that working for us? I mean, what does that look like in terms of our perception when we walk in? Do we feel the same way, do you think?
No, and it's not working, obviously. That's why we're here right now. So as we know, every institution, hospital setting, doctor's office, what have you, they have their policies, they have their procedures and protocols and guidelines, what have you, even their informed consents. But it's not geared towards us. You know, it doesn't include us. They just want to make sure, you know, check the box, patient in the room at this time, make sure you write the time, make sure you do this, make sure you communicate X, Y, Z. But you have to step outside of that and look at the individual patient, you know, just like to Lucinda's example of the pain scale. That's standardized across the country. Pain scales, either smiley, you know, smiles or frowns or numbers, you know, and they look to, oh, she said her pain is a 3. You're like, oh, okay, that's not bad. A 3 can be 10 for someone else, you know? So you really have to start looking at the whole person. Her 3, is she crying? Is she cringing? Is she holding herself? Is she moaning? You know, you have to go beyond these protocols and policies and procedures a lot of the time, most of the time, and really hone in on the patient. And the other thing, you know, that bothers me is that these institutions, they look at their own statistics and outcomes and feel like, okay, well, we didn't have a maternal death, or we, you know, our maternal morbidity is this percentage. It's not as high as that institution in that state or what have you. And it's like you have to step away from that. And like Lucinda said, everyone has an experience. Look at those experiences. So the outcome could be great, but how was her experience throughout her pregnancy? Was she discriminated against? Was she abused? Was she disrespected? And if so, that's what needs to be changed. That's how you change your policy, not the statistics. It's the experience that matters.
Right. Now, I'm wondering, how do we help empower Black women, the average Black woman, not the Serena Williams of the world? How do we help to empower them to speak up and push back, you know, when they're entering an organization like the healthcare organizations in the United States?
Yes, and that's an important question because, you know, the healthcare system, our healthcare system is very complex. Even as a nurse midwife, I was terrified when I went in. I still had to rely on people to ask questions and to advocate for me. Because when you're in the hospital and you're worried about your baby, you're worried about the pain of labor and how you're going to respond to that. When you have all those pieces and then you have other people making decisions, it's difficult. I'm saying the provider making the decisions for you, it's difficult for you to say, you know, I'm not sure I want that, or tell me more about what is it you want to do. So what I'm doing with Lucilles House is really providing that education on an individual level for women during their pregnancy, helping them, again, not telling them what to do, but giving them the information they need to make a decision or a choice. And I'll give you an example. Like I had someone who was on antidepressants and her doctor wasn't really telling her if it was a risk for the baby or she should continue them. So she wanted to stop. So I talked to her and I said, you know, let's look at your medication. And we looked it up. I showed her the side effects. And I asked her, I said, who are you when you're not taking your medication? And do you want that environment for your baby? So I said, but these are the questions I want you to ask yourself and you decide. And remember, it's your body, it's your choice. And she decided to continue on her medication. She was like, I'm not going to stop. But I also gave her the tools to go to her provider to ask the questions, to say, you know, tell me more. Because sometimes they'll give you an antibiotic or, you know, pain medication or even your vitamins. Even like vitamins that have iron cause constipation. So tell the patient if you're giving that to them. But sometimes the patients are overwhelmed and they're like, well, they said I need this. So when they start experiencing side effects that could be normal, they'll stop taking it. So anyways, it's just important to keep in mind that, you know, that the education is important, but to allow the woman to make her own decisions about what it is that they need. Right. So that's an important piece.
Yeah,
that's huge for me. Patient education, to empower you to be your advocate and to really be informed, to make that informed consent, to sign that dotted line for the care or the treatment. And just like what you were saying with the provider-patient relationship, if that provider really, you know, cared for, provided all the information, not no information or limited information, you know, having that, I feel like sometimes providers have that that power struggle, you know, it's like, I know best for you. It's like, no, the patient is a center of care, you know, her and her team, whoever makes up her team. And that's what we need to do is you know, provide her with that power and that autonomy to make those decisions. And I've seen where if patients, you know, they don't want to do what the provider says, made that decision, she's looked upon as uncooperative, not compliant. I've seen patients discharged from practices because she didn't want to do whatever the provider wanted her to do, even though it's her own body. It has to change. That has to change.
Yes.
Yeah.
And I just want to say quickly on that, even someone asking questions, the provider gets like defensive. Like, how dare you question what I'm telling you to do? And they make the patient feel that way. And I feel like also women need to know, really anyone, that if you have a provider that's not listening to you, you have a right to change. You don't have to continue with that same provider, because a lot of women feel like they have no choice, or they're afraid I'm going to have to learn somebody new. But when you go for your visits, if you're feeling uncomfortable, you feel stressed, because remember, pregnancy itself is stressful. Because you're looking at, am I eating right? Am I doing this? So going in to see your provider, that shouldn't be a whole nother level of stress. So if you ask a question, and your provider should be able to answer any question that you have. And I'll give you this quick example. I had a patient come in to see me that had a scratch on their leg that got infected, and they brought in pictures from Google saying that they had gangrene. And I said, but that's important to them. I couldn't just be like, oh, no, you don't got that. But I said, you're not at that point, still taking them in, any question, still just take a minute to address it, because they're worried. And Google takes people places they don't want to go, but you have to be prepared for that as the provider. So, and your provider shouldn't be upset with you. Your provider should say, no, you're not at that point yet, but let's talk about it.
Right.
So anyways, you just have to feel comfortable.
Yeah. Lakeisha, at one point you were a new nurse to the field. And Lucinda, you you teach nurses, right? And you get them out there. I mean, how do you train nurses to be cognizant of implicit bias, and also to be able to communicate in a respectful way, regardless of their race and ethnicity, in a respectful way to women, particularly Black women who've historically been devalued?
Yeah, Lakeisha, do you want to start?
Sure. So I feel like, it's when you go through nursing education, you learn the core values of nursing, and it's 5 of them: altruism, autonomy, human dignity, honesty, integrity, and social justice. So if you really ingest that and live by that, work by that as a nurse, we wouldn't be here. You would be that drive for nursing care. And for me, I would consistently remind the new nurse about that. You are here to give respectful care to everyone, no matter their color, but especially the Black community, because of the long history. So you need to listen intently, listen more, and be an advocate for, because they're not going to have that advocate. They're not going to have that ally. You are it, period.
Yes. And we have to do better as healthcare providers. We have to do better at how we educate our nursing students, our medical students. We have to do better at that, because our textbooks are full of a lot of lies. Even our maternity textbook basically says that Black and Hispanic women exaggerate their pain. And I use it as a way to teach, because I'm like, this is not true. This is foolishness. Take these pages and rip them up. But other people teach that to them. Other people say, oh yeah, so they're perpetuating this long history that we know. And also where that history dehumanizes Black women. It makes us look like how they looked at us back then, like we were comparable to animals. And unfortunately, people still have those beliefs about us. So when we're in pain, they could look at us suffering and say, oh, she's all right. I was in there 5 minutes ago. I'm not going back in that room right now. So it's important for students to know and understand that history so they don't become a part of that. And they have to understand how to look at patients holistically and get out of the textbook, get out of what that old nurse that's been practicing for 30 years, making everybody miserable. Don't follow her.
Right.
It's like we have to really break that behavior up. We have to stop that. But people who are coming up, we got to let them know how you look at your patient is important to health outcomes. So you have to learn how to do an assessment, how to talk to someone. And I say any community that you go in, especially let's say you go in a community that's predominantly Hispanic Latina. When you go into that community, learn their history. If you're working with Native American women, Indigenous women, learn their history so that when you provide care, you're sensitive to that. And you're not just repeating the same patterns of abuse, of trauma that the history has in our medical system that we have seen. So it's important to acknowledge it, even though students are uncomfortable. But I see students in my class that never interacted with people of color. And then we're going to have them work in an environment that's predominantly people of color. So we really have to, again, break that cycle of them learning all that things that build up implicit bias and dismantle that. and have them learn to look at patients, each one individually.
Yeah. The thing about it is, and I'm pushing back a little bit only because I want us to think about it, not necessarily because you may have the answer. I'm concerned because when you're working at hospitals, not unlike social workers, there's a hierarchy, right? And if you're new, you know, it's known that you don't really have much of a voice. And of course, in terms of the hierarchy, doctors are at the head of it or at the top of the hierarchy. How can a new nurse navigate all that?
That's an important question.
That's a great question. So I would say from experience being, new nurse, obviously of color, I know that I've had to ask more times, speak more times, request more times than my white colleagues. So that was one thing that I noticed right off the bat, especially advocating for a patient I had that was of color. So I literally have to observe those providers and the ones that I felt comfortable going to, and observe the ones that I saw that would be an ally, because, as my mom would say, talk is cheap. They can say one thing, but do something else. So I would go to, there's a medical director and that's over every department. So if you have to go to that medical director, go to that medical director. There's a nursing director, go to the nursing director if you can't go to the nurse manager. And then over that is the VP of nursing, go to her. It's the chief nursing officer. There's levels that you can definitely go through and speak your truth and what you're observing. Someone will listen throughout that line. Someone will definitely listen. There's someone there. If you have to literally jump everybody on that floor and go up to the highest level, then you do just that.
Yes.
Yeah, and you have to be comfortable in doing that, right? Because
Yep.
you also have to think one of the outcomes can be I can lose my job.
Mm-hmm. Yeah.
You're right.
Yeah.
You're absolutely right. And if that's the case, then you can go against, go to HR and report. You can go to, you can make a complaint to the labor department. Like it's things you can do,
Are we teaching those things to nurses? Are we teaching those steps and those procedures to nurses so that they know what they can do? I mean, I know we don't do it in social work. I'm just going to say that as a social worker, we definitely are not saying that,
Yeah, in nursing, we have to do better in that area.
Mm-hmm.
I can tell you, like I work with senior level students and I talk about racism. And a student said, if a white student said, if someone does something to a Black nurse or a Black patient, we're told to advocate, but we're not told how to advocate. Mm-hmm. And it's a system that you have to navigate and you learn. When I first became a nurse, and it was 30 years ago, please don't do the math. But when I was a nurse, I was so naive. I was so naive. I didn't even think nurses could be racist. I thought when they went to the hospital floor, when they got on that floor, they took care of the patient. They just took care of the patient, no matter how they felt when they were home. And I had a rude awakening. But I also realized that the system is set up where you feel like you don't have power, but we have power. The system is created that way so that that provider who disrespects a patient, you stay silent and that provider continues to work. That's the thing that if you talk to women, they'll tell you about that same provider 20 years ago that people are talking about now, because we're silent about the behavior. But we have to find sources of support. I always say for nurses, go to your local nursing organizations. If you're a Black nurse, the Black Nursing Association, if you're a Hispanic Latina nurse, a Hispanic Association, because that's where you could get support and you'll find people who know, because it's a game. We all know I could go down to human resources and then next week I'm written up. So when I go down to human resources, I got to use the right language and say racism, discrimination, because when you use those words, they have to research it. Mm-hmm. And you cannot be retaliated against. But if you don't know how to play the system, especially nursing, I would say the healthcare system, these hospital organizations, I'm just going to say it, they're a mess.
It's the
And they
beast.
know they're a mess. They know it. So even though you go down there and they act like, oh, we didn't know that that doctor was like that. They know that doctor was like that. They don't want you to know that. And they do things to keep you silent. But we have to do better at just exposing the system, but letting people know you have a right to have a safe work environment. And sometimes you're seeing a patient mistreated, that traumatizes you too. And you go home saying, oh my God, I should have said something, and then that wears on you. So it took me years later. It's not easy. It took years later for me to find my voice. And now I'm like, what's the worst that can happen? Because that's an environment that I should be working in if I can't feel safe to speak up and advocate for my patient. Because that's the hospital's mission. That's what they say in their patient bill of rights. So if you can't work in that environment where they honor that, is that an environment where you need to work? So it's difficult. It's a difficult situation. But the more we speak up and the more we speak up together, then that's when we could see impact change.
Yeah. Do you see that there's a need for mentoring new nurses in the field or new health professionals?
Yes, yes. Mentoring new nurses and weeding out those nurses that cause harm, because they've been around for a long, long time. Weed them out, because it has to be set that we're no longer accepting patients when they tell you they have pain and you take 3 hours to go in the room and treat their pain. Or they say they have pain and you send them home. We got to have a system where we say, you know what, that's not acceptable, and have some accountability. Because if we don't have the accountability, we're going to keep seeing these health disparities among Black women 10, 20 years from now. Because what we're talking about is not new. So we have to do something to break that cycle. But unless we have people want to change the system, we're going to keep having the same thing over and over, just continue to happen.
Yeah, I recently saw an apology from the American Psychiatric Association, where they apologized to Black, Latino, and Native American people for systemic racism and for pathologizing them, and it took hundreds of years for them to do that. And so we're now needing to look at social work to see how we have been framing our theories when it comes to working with people of color. And thank God we've gotten this apology, but I don't even know that the social workers in my, are using that, understand it, and are also sharing it with their students, right? To help them understand this is how systemic racism shows up in a professional way, right?
Yes.
So that's incredible.
Yeah, and if my history as a Black woman in this country is not acknowledged, I will never be respected as a professional in this healthcare system. It's painful to do, but we have to acknowledge it. How do we move on if we don't acknowledge it? Just think about, you have that argument with your best friend and you cuss them out. You can't show up the next day and be like, hi, I brought breakfast for you. You can't do that because your friend's going to remember until you acknowledge what happened. But that's our country. And we even see politicians trying to come out to make laws so that you can't talk and make white people uncomfortable. But I'm like, I'm uncomfortable, so you could be a little bit uncomfortable. But I also look at this as racism kills. These structural policies, they kill our women. We're seeing it, so we can't deny it.
Right.
But if we don't acknowledge it and try to do system changes, it's going to be the same thing over and over and over again.
Yeah. I'm going to ask Megan to take a look at the chat to see if there are any burning questions that are coming up. And then for those of you who are actually on, if you have a burning question, just put your hand up so I can see it, or Megan can see it. But in the meantime, I wanted to ask about doulas. I have very little knowledge of a doula. I mean, I know what a midwife is. And so I want to ask, what's a doula and how do they differ from midwives?
Okay, and Lakeisha and myself, we both are working to advocate to have, women have support in using doulas, and we're both nurse midwives. So nurse midwives have like a they're healthcare professionals. They have the training in nursing and midwifery. There are midwives that do not have that nursing piece. They don't want anything related to nursing. They just want to practice midwifery. So you'll see that as well. And we have some doulas I actually see Callie King. I want Callie to say something. Could she say something? Because she's she's been a doula for years. So she could explain it. I don't want to mess anything up. So Callie, would you mind?
I'm sorry, it's loud where I'm at, but I'm a doula. I've been a doula for 25 years. Professionally for 1 year, we provide education. We provide support to not only the birthing person, but to their support team. That could be mother, grandmother, whoever. We advocate. They tell us not to advocate, but we advocate for the clients. I've been doing this for so long that it's second nature to me. I've put in a chat how I will speak to the perinatal director. I will go beyond what I'm supposed to do just to advocate for people in birthing spaces. We do childbirth education with them. We do comfort measures. We do it all. And we don't only, the misconception that people have about doulas is that we only support natural birth. We support natural birth. We support C-sections. We support anesthetized births. We support you at home. If you were in your backyard, if you were in the forest, wherever you are, that's where we meet you at. And this is, this is who we are. My oldest doula baby is 25. So we've been doing this for a long time. So we give that support. Okay, I'm gonna get off because it's loud. I'm so sorry.
Thank you. Thanks for joining us.
I put her on the spot. But doulas, the other things I love about doulas is they know the communities they're from. And it's even better when they're outside of the hospital system. When you're working in the system, you still got to follow their policies and things like that. And people always worry. I just heard a nurse recently, oh, we're just worried the doulas are going to tell us what to do. And I'm like, that's not what doulas do. Doulas advocate, and they're doing what their patient, they work for the family. They don't work for the hospital, they work for the family.
Right. And there's also research that's come out that doulas, there's decreased C-section rates when patients uses doulas. So I know that.
So morbidity decreases for Black women when you use doulas?
Oh, absolutely. Absolutely. Okay. Because they're there. They know the patient. They're there. They're advocating. Yep. Okay. Absolutely.
I see Sherry has her hand up. Sherry's my niece, and she's coming in from New York. Right, Sherry?
Yes, I am. Hi. Majella's here too. So as someone that works in healthcare, but I've been working in healthcare for like a solid 10 years now, I find that the relationship between the nurses or the patient, particularly when it comes to patient care, the patients and even those below in positions below the nurses tends to improve the outcomes of patients. So like, for example, if I have patients that I see on a regular basis, you get comfortable with them, you start having jokes with them, and then you notice they come in and they're not looking exactly the same that they were beforehand, or like the week before. You'll like, you'll, as a person who's non-clinical, we could bring it up to the doctor. Hey, have you noticed X, Y, and Z happening to the patient? I don't know. This is for the nurses essentially. Do your hospital environments encourage the non-clinical staff to like be a silent, but they're advocate for the patients that they see on an ongoing basis?
Yeah, that's a huge problem. And I'm not practicing in a hospital setting. I can tell you about like medical assistants, clinical assistants that work with patients in these systems. A lot of times they don't have a voice, but it depends on the provider, because the provider knows and understands that patients will tell them things that they may not discuss with them. So if you have a provider that acknowledges that, then they'll take that information and use it to care for the patient. But you can have providers that you go up to them and say, oh, this patient, she told, she's going through this, or this is happening to her, and they don't want to hear that. So it all depends on the provider. But the important thing, and this is for, people are always like, who's on the healthcare team and who's not? We're all a part of the healthcare team. To me, it starts at the front desk. Because when you come in, that person is the one who gets your information and sees where you're at. But I have to tell you, I've gone to some front desks where people don't even look up at me. Then when they finally look up and acknowledge me, where's your insurance card and your license? You know, I'm like, hello, I'm here because I have a lot of pain. I need to be seen right away. There's people who don't want to do that. But that's why I say that's a part of the healthcare team, because that's when the healthcare experience starts. So it's important for each member of the team to be recognized and acknowledged. And sometimes, and this is a scary part, is that, you know, I'll even say this as a nurse midwife, I learned how to assess and how to treat certain things. But there still are things that could be outside. I call them blind spots. There are still things I may not see that's going on with my patient. So someone else could say, you know, that person just lost their home, or that person's in a shelter. Those are things that are important to their care. So I'm okay with someone telling me that. And providers, we have to do better at realizing if we want to improve health outcome, especially when we're looking at maternal health, we need all hands on deck. We need anyone who touches or interacts with that patient to be a part of their care and making sure that they have safe passage through their pregnancy, childbirth, and postpartum. So we have to do better.
Right. And I agree. I'm working on a group that's looking at experiences of birthing people. And like Lucinda said, it's going to be a qualitative study where we're looking at, like you said, the front desk. We're going to look at the medical assistants, even in the hospital, the housekeeping, the admissions there, valet parking. I mean, every single person, because every person, like Lucinda said, that patient have a contact with, conversation with, communication with during her experience, that's what's going to matter. So that valet driver can make or break her day. If she's screaming in pain and the valet driver is giving her a hard time to park her car, she ends up breaking the water, having a baby, like whatever, that can turn into a traumatic birth experience. So it doesn't matter if it's clinical or not, that everything has to change. The system has to change.
Yeah.
Sorry, I'm going to just quickly say, I find that I've noticed in like the years that I've been in healthcare as like the ones underneath the clinical team, that they kind of, if you ever see, not say ever, but like some people, when they're in the front desk and you see that they keep their head down and they're not actively looking at you, I feel that that shows you what the potential culture of that location could be like. Because
I
honestly,
1000% agree.
I've had situations where at my job where they do this thing called Press Ganny, which is like a survey that happens. And so in the survey, they I would have like my job used to acknowledge the surveys, and people would literally say the best part of my treatment is seeing Sherry when I was working in the front desk. And so like I absolutely understand, especially when you're in pain, how even just starting off with a joyous person or starting off with someone that shows you that they care, you could probably get a lot out of them as a non-clinical, which you can report back to the clinical side, but also just starting off in a better mood can make the whole experience a lot nicer.
Yes.
Absolutely. Absolutely.
Yeah.
Yeah, but you're an important part of the team.
I'm sorry, what'd you say?
Oh, no, I was saying she's an important part of the team.
Yeah, absolutely. So we're winding down. I'm going to ask if anyone else have a question, let us know. But Lucinda, in the meantime, can you tell people of what Lucilles House is all about, and just share some information, Megan, about the April 16th, April 16th event? Yes.
So Lucilles House right now is a virtual space, but we'll be changing hopefully to a physical space in the future. So I started Lucilles House because I'm tired of the disparities that exist. I'm tired of hearing women who give their experience, when your birth experience is supposed to be a beautiful experience, and you're thinking about how that person mistreated you. So my goal is really with Lucilles House is to address maternal mortality, but also to empower women of color, particularly Black women, but all women of color, so that they can understand that, how to navigate this healthcare system. I want to address things on an individual level. So I'll be doing individual consultations, but I'll also have educational workshops and classes and community events. but we also offer support. And if somebody wants a doula and they need a financial assistance with that, we're offering support with that. If somebody even wants midwifery care or other things that can take stress out of their pregnancy, we have funds that will support that. So, so I just wanted to just let people know that we're really looking at addressing things on the individual level, but also through our talks, if there's system issues that come out, we want to bring those up and address that. So there's an advocacy piece as well.
Okay, thank you very much. My last question for you this evening is, if you had one message you wanted to share with our audience about Black maternal care, healthcare, what would it be?
Yes. Oh, sorry, Lakeisha, I thought you were gonna go.
Oh, I'm like trying to think of what, I have a lot of things I could say, so I'm trying to
Yes, yeah, that's the thing. It's hard to narrow it down to one.
narrow it down. Right. Oh man, Black maternal
So
healthcare. Okay,
I think,
go ahead.
Oh, go ahead, Lakeisha, sorry.
No, go ahead. Go ahead.
So I think for me, the most important thing is that for when you enter the healthcare system, you have to be greeted by people who look at you as being human. I think that's the essential thing that I feel like sometimes we're dehumanized. So I just want people to acknowledge that we have, we have value. We have the right to feel safe when we go into for care. And I always go back to history. When you look at like in the 1940s, where there was segregation, Black people didn't have civil rights, and health outcomes were better when you had a woman from the community delivering your baby. You're like, you look at now and you're like, I have my rights. I can go to any hospital I choose. Well, almost, because you still have insurance that could create a barrier. But it's like you realize that things are scary because you don't know what to expect. And unfortunately for Black women, we're wondering, am I even going to come out alive? And that's the scary piece. So my thing is that we just have to change the system. We have to acknowledge that as a people, this is what we need to move forward. And we have to do what we can so that we can get there.
Thank you for that. And Lakeisha?
So my advice would be to empower yourself. Seek that information, and don't be ashamed to ask the question and ask it again and ask again if you don't get the, if you don't understand it. There's nothing wrong with a second opinion. There's nothing wrong with going somewhere else. Like Lucinda said, if you're not feeling like you're being respected as a human being, if you're not feeling your questions aren't being answered thoroughly to you where you can understand, if you're not feeling that you're having an overall great experience, like we said, you should be enjoying your pregnancy. I mean, besides the discomforts and things like that, but you should not feel any apprehensions of going to the doctor's office. If you're not feeling great about this, please go somewhere else. But know that you are the center of your care. It is your body. You make the decisions. You ask the questions. You demand the answers. You demand the best care.
Mm-hmm. Thank you for that. I did see a question that asked, how did COVID-19 impact Black maternal health care? I think we have a minute or two just to respond to that.
Sure. And there was another question that Cameron brought to my attention, but COVID-19, and this is the issue, like COVID-19, a lot of us, when things first happened, we didn't know how severe things were. And it just kind of blew up. It was like one person had COVID and then it spread through Connecticut like crazy. It spread throughout the country like crazy. And pregnant women, especially Black women, were the most vulnerable. And when you look at the statistics, going up from 44 per 100,000 to 55, we know that COVID had a role in that. But with COVID, it allows certain policies and procedures be pushed that they couldn't have somebody in childbirth with them. So that was one last person that they had advocating for them. So, and then it just had an excuse to do a lot of things. Well, we have to do this way because of COVID. So I think that caused a lot of harm, and especially pregnant women, placed them at risk for mental health issues, like postpartum depression, things like that, because they were very isolated. And again, the loss of choice during childbirth. So COVID-19 really hit this community hard. And Devin, Devin, Devin had a question about an instrument to measure the patient's experience. And Dr. Karen Scott is working on a tool that tries to capture like discrimination and racism, because there's a lot of tools that don't capture that. Even on hospital evaluations, when they ask about your experience, there's nothing about if you felt like you were discriminated against, right, or you felt that you experienced racism, because I think hospitals would be really shocked about those results. Mm-hmm. So anyways, I just wanted to mention that.
Great, thank you. All right, guys, thank you all for joining us. We've come to the end. Just keep in mind that Black maternal health is really significant. If you know of anyone who's pregnant or about to be pregnant, please try to get them as much education as possible so they understand that if they're at risk in particular, that there are resources out there such as Lucilles House that can be helpful to them, but also that they should feel empowered to push back and ask questions and educate themselves as much as possible about what it is that they're experiencing. Okay, any last words? And this can come from the audience as well.
Okay. I just want to say that you just keep in mind that there's people in the community who are working to make sure that you do have the childbirth experience and the pregnancy experience that you want. So please look, there's doulas in the community. Again, I'm mentioning Lucilles House again, but there's a lot of resources that want you to have a good experience so that you don't have to go through your childbirth alone or afraid. They will give you the resources and accurate information to help you.
And also I put a link in the chat for my podcast, which is Inside Out, Outside In, for those of you who came in late. So feel free to access this conversation or browse the, we have 3 seasons of conversation that bridges the gap between academia and the community. Feel free to do that at any time.
Okay, thank you.
Thank you, guys.
Thank you. Thank you.
Thank you.
Thank you for the awareness and bringing this in, this enlightenment to us women. Very powerful message. Thank you.
Appreciate it. Thank
you.
you.
Thanks.
Okay, take care. Hi, Erica.
Will this be posted anywhere as a recording?
Yes, it would be on the Inside Out, Outside In podcast. And when Lucinda's website is up, she will also have it on Lucilles House website.
Okay, thank you.
There is a link in the chat for the podcast.
Inside Out, Outside In.
Yes, I'm going to put it in the chat right now.
Okay.
So you could copy and paste.
Thank you.
You are welcome.
Thank you for coming.
Yeah, absolutely.
Aaron, thank you. Okay, should I stop the recording?
Yes.
It's gonna go to your iCloud.